Welcome back to another COVID-19 video. In this video, I want to talk about why so many COVID-19 patients in the hospital are developing blood clots, and should we empirically give high doses of blood thinners to these patients who are in the hospital. So that's what we're going to tackle in this video. But before I dive right in, let's look at a very interesting report that was published based on a study of patients who had severe COVID disease with ARDS. This study was done based on patients in Italy by the famous Dr. Gattinoni, who I think of as the godfather of ARDS. I mean, this guy was publishing research articles about ARDS while I was still in diapers. Let's start off by taking a quick look at what a normal CT scan of the chest looks like. Black represents air and bone is white. If the patient receives IV contrast, the blood vessels will look white. But the important thing to notice here is that the lungs are normal. Now, let's take a look at Dr. Gattinoni's study. What he found in his study of COVID patients with severe ARDS is that there seems to be two types of ARDS. First, take a look at the PO2 to FiO2 ratios of the patients in the study, where it says 95 millimeters mercury and 84 millimeters mercury. These are extremely low levels of oxygen. These numbers are telling us that these lungs in these patients are having a very difficult time getting oxygen into their blood. In half the patients in the study, the patients had the typical ARDS that we all know and hate, which causes tons of inflammation with fluid and debris filling the alveoli, where the chest x-ray and the CT scan of the lungs looks horrible. This is depicted in the bottom CT scan. Let's take a closer look. Look at all that grayish crap filling up the lungs. That's not supposed to be there. This type of ARDS is what's known as the H type. H refers to high elastance, meaning lots of stiffness in the lungs. These lungs are very stiff, which does not bode well for lung function. But then there's this other type of ARDS, which the other half of the patients in this study had. These patients' lungs have some of that grayish crap, meaning there's some inflammation going on there, but it's not as much as you would expect given the degree of their hypoxemia. In other words, the oxygen levels are far below what you would expect given the degree of inflammation that you're seeing in the lungs. This type of ARDS is known as the L type, meaning these patients have low elastance, meaning their lungs aren't very stiff. So with this L phenotype, there's something else besides inflammation that is contributing towards their very low oxygen levels. And it can only be one of two things, or a combination of these two things. And that is one, constriction of the arteries that deliver blood to the lungs. In other words, pulmonary vasoconstriction. And this is essentially pulmonary hypertension, meaning the pressure in these arteries is high. This means that there's less blood being sent to the lungs to pick up oxygen, and this by itself can cause low oxygen levels. The second thing is the development of clots within these arteries and capillaries, and this also impairs the ability of the lungs to get oxygen into the blood. So what exactly are blood clots and why are they so dangerous? Blood clots don't normally form in the body unless we have bleeding, for example, if we cut our finger. That's how we heal, right? The clot stops further bleeding. But sometimes, some people form clots when they're not supposed to. Our blood, besides being mostly water, is made up of a bunch of different proteins with different carbohydrates and fats, and these different chemicals interact with each other. And all it takes is one piece of the puzzle to be missing or abnormal to totally throw off the balance of either clotting too much or not clotting enough. For example, hemophilia B, these patients are missing a protein called factor IX, and that's why they bleed more than they should.
If it bleeds, we can kill it.
No, Arnold, that's not what we're going for here. But some people could have the opposite problem where they clot too easily, and they form unwanted blood clots, which is what happens with, for example, antiphospholipid antibody syndrome. And that's why these patients need to be on a blood thinner. So antiphospholipid antibody syndrome is not only a mouthful, but it's a pain in the ass because it has a tendency to cause clots in both veins and arteries. But guess what? It's not the only cause of abnormal clotting, as there are hundreds of other medical conditions that can do the same thing, such as factor V Leiden and prothrombin gene mutation, or antithrombin deficiency, or protein C and protein S deficiency. Regardless of the cause, when blood clots do form, they're most commonly in the deep veins of our legs and sometimes our arms, although they can form anywhere in our blood vessels. When blood clots form in our deep veins, it's called deep vein thrombosis, and the most common symptoms are swelling and pain. So deep vein thrombosis, or DVT, these are dangerous because they can break off and travel to the heart and to the lungs. And this is called pulmonary embolism, which can be fatal. And there are plenty of people who die every year from pulmonary emboli. Sometimes the clot is so big that it causes death within minutes. Thankfully, not everyone who gets a blood clot in their lung dies. The most common symptoms of pulmonary emboli are shortness of breath, chest pain, and sometimes cough. They can also have lightheadedness and dizziness, or even temporarily lose consciousness. And some people don't have any symptoms at all. It usually depends on the size of the clot. Sometimes clots can form in the arteries and cause a stroke, or they can lodge in the coronary arteries and cause a myocardial infarction, meaning a heart attack. Or they can cut off blood flow to a leg, which is what happened to this doctor, remember?
It's an aneurysm that clotted, leading to an infarction.
But this also happened to someone with COVID-19, Broadway star Nick Cordero, who, unlike Dr. House, had to have his leg amputated as a result. And there are more reports of patients presenting to the hospital, not with typical COVID-19 symptoms, but symptoms of pulmonary emboli. This is this patient's CT scan of the chest. They used IV contrast to do what's called an angiogram. So this is called a CTA of the chest, or CT angio of the chest. This is in the coronal plane, meaning in this view, it's like you're facing the patient. The contrast given makes the blood vessels light up in bright white, and when we see a dark spot where it's supposed to be bright white, that's how we identify the pulmonary embolism. This patient also had bilateral ground glass opacities, or infiltrates, if you will, which is representative of fluid and or inflammation. This patient was admitted to the hospital, was treated with a blood thinner, and was eventually discharged from the hospital. So are blood clots at least part of the reason why some people with COVID-19 are dying? I can tell you that the number of clotting problems my colleagues are seeing in the ICU across the country, all related to COVID-19, is unprecedented. But this isn't just a bunch of doctors and nurses that I know who are reporting this. There's actually a recent Dutch study that found that 184 patients in the ICU with COVID-19 pneumonia, 20% of those patients were having clotting issues. There was also a similar study in Wuhan where 25% of hospitalized COVID patients had clots. Why and how is SARS coronavirus 2, which invades the cells of the lungs, specifically the type 2 alveoli, how is that causing blood clots to form in the body? When someone has a severe case of COVID-19, it's causing a ton of inflammation within the lungs. This inflammation is what's triggering the blood clots to develop. We knew this happens with ARDS even before COVID-19 came around. So if you saw my video on how COVID kills, you may recall how I was talking about how with ARDS, these patients usually develop microthrombi, meaning tiny clots that form in the tiny blood vessels in the lungs. And these microthrombi can combine to form bigger thrombi, meaning bigger clots. This happens at least partly because of the cytokine storm that develops as a result of the infection. Blood clots are also a concern with seriously ill people in general, regardless of what illness they have, because these patients aren't moving much, if at all, and the lack of movement further predisposes one to having clots. And that's the exact reason why when patients are admitted to the intensive care unit, we usually give them blood thinners unless there's a reason not to. For example, if they have bleeding, we don't want to give those patients blood thinners. But when we give these blood thinners, we're giving them in prophylactic doses, meaning the intention is to reduce their risk of developing a clot in the first place. But these prophylactic doses are considered low dose, and the chances of someone having severe bleeding from these small doses is very small. But the blood clots with COVID-19, these are just a whole nother beast. So how and why is COVID-19 causing more blood clots than usual? Like everything else in life, it's complicated and we still don't have it figured out. Check out this diagram. Actually, don't. It's really complicated. I'll summarize it for you. Long story short here, the virus enters the alveolar cells in the lungs using the ACE2 receptor. And once it does that, it causes the cell to have less ACE2 receptor on its surface. This increases the amount of three things within the lungs. 1, inflammation. 2, formation of clots. And 3, constriction of blood vessels going to the lungs, meaning pulmonary vasoconstriction. And guess what? Each and every one of these things by itself can lead to low oxygen levels. So you can imagine what that means when you have all three of these things going on at the same time. The way that oxygen gets into our blood from the alveoli, it has to diffuse from the alveoli to our capillaries. But in those capillaries that encapsulate the alveoli, there's destruction there as well. The inflammation and the cytokine storm is going on there in the capillaries. not just the alveoli. The lining of these capillaries is called the endothelium. Perhaps you remember this drawing from yours truly. Pay attention to the wall of the capillary. This lining is called the endothelium. The cytokine storm causes destruction of the alveolus and the endothelium, and this, my friends, is a trigger for clotting. We knew this happens in ARDS even before COVID, but guess what? The virus that causes COVID can actually invade the cells here in the endothelium because these cells have ACE2 receptors as well. And that can cause even more inflammation and more clotting. And this study, which looked at autopsies of 2 patients, found blood clots in the lungs and just beneath the surface of the skin. The autopsy results showed that within the lung, there's lots of destruction of the capillaries that surround the alveoli, exactly what I was just talking about. They also found blood clots beneath the skin's surface on 3 living patients. And in another published report in the New England Journal of Medicine, there were 3 patients in the ICU who had COVID-19, and these 3 patients developed blood clots that were significant enough to cause major blockages in blood vessels. These 3 patients were positive for anti-phospholipid antibodies. More on that in a bit. Let's take a look at the first case here. It's a 69-year-old male with a history of hypertension, diabetes, stroke, who comes in with fever, cough, shortness of breath, and diarrhea. Also had a headache. He developed lower and lower oxygen levels to the point where he required intubation with mechanical ventilation. He also developed ischemia in both legs and in some of his fingers. Ischemia means he's not getting enough blood flow to a certain part of his body, and in his case, it was to his fingers and to his legs. And when they did a CT scan of his head, they found that he had multiple areas of strokes. When they did blood work on him, he had low levels of platelets, he had elevated prothrombin time and elevated partial thromboplastin time. He also had elevated levels of fibrinogen and D-dimer. As it turns out, he was positive for anti-cardiolipin IgA antibodies, as well as anti-beta-2 glycoprotein IgA and IgG antibodies. So, what's the diagnosis? That's right, anti-phospholipid antibody syndrome. The other 2 patients in these case reports basically had the same story and the same diagnosis. These antibodies that I just mentioned are not in the blood for the vast majority of people. These anti-phospholipid antibodies are bad because they attack the phospholipid proteins in our body, and if it's severe enough, they can cause major clots to form in our blood vessels. So anti-phospholipid antibody syndrome, it's a condition that depends on someone's genetics. But these antibodies can also arise transiently in patients with critical illness and various infections. So do all patients with COVID-19 who have blood clots, do they all have this transient anti-phospholipid antibody syndrome? We don't know yet. So here's what we know so far. Even though there are lots of gaps in our knowledge with this disease, there's all the stuff that happens in the lungs that we just talked about. But also there's the cytokine storm that is triggered in the lungs that can affect other organs in the body, such as the heart, the brain, and the kidneys. And as if that's not bad enough, just about all the other organs in the body have ACE2 receptors, such as the heart, the brain, and the kidneys. So inside the body, COVID is causing a Category 10 hurricane in some people, about 3 to 4% of people who get the virus. So besides looking at drugs to treat the infection, we also have to consider giving big doses of blood thinners to patients with severe disease, even if we're not able to diagnose them as having clots. Now, some might say, well, doc, why can't you just diagnose them with clots? Easier said than done, even during normal times, but it's especially harder to do this during a pandemic. Every test we do, whether it's an ultrasound of the legs looking for clots there, whether it's getting a CT scan of the lungs looking for a clot, or a CT of the brain looking for a clot that's causing stroke there, all of these things require more PPE, more potential exposure to the healthcare staff, and sometimes doing these things have more risk to the patient during certain tests. For example, like doing a CT of the chest where we give IV contrast. All these things have risks. But even if we do all these tests and they come back negative, there's still the possibility of a false negative because no test has 100% sensitivity and 100% specificity. In other words, no test is 100% accurate. So there's going to be times where you have a very sick patient with COVID-19 in the ICU and you don't know if they have blood clots. The question becomes, should you give them a high-dose blood thinner, meaning should you treat them as if they have blood clots? Not an easy question to answer, because the risk of life-threatening bleeding increases when you give them that high-dose blood thinner. And based on the studies I mentioned before, it looks like about 25% of COVID patients who are in the ICU do have clots. So one clue that might make us more inclined to give high doses of blood thinners would be to check their D-dimer level in the blood, because very high D-dimer levels are associated with more severe COVID disease. The problem with that is just because someone has very high D-dimer levels doesn't necessarily mean that they have clots, because it's a very non-specific test. We know that there are 1,000 causes of high D-dimer levels because inflammation in general is a very well-known cause. I mentioned before that even before COVID-19, we knew that ARDS causes these microthrombi, and that's why in the past, there have been studies that looked at giving these patients different forms of blood thinners. These patients didn't benefit from the blood thinners as they actually had more bleeding and ultimately had worse outcomes. But these studies don't apply necessarily to COVID-19 ARDS because this ARDS is a whole nother animal. Also, the blood thinners in these studies were not the typical blood thinners that we use today, so that's another reason. Unfortunately, because this disease is so mysterious and so new, with relatively few high-quality studies, doctors don't have much to go on when it comes to treating these patients. We're going to have to make difficult decisions, especially when it comes to giving a high dose of a blood thinner in the ICU. If we see that the patient has a blood clot, then the answer is easy. Give them a blood thinner as long as they don't have bleeding issues. But if we don't see blood clots, it's a difficult decision that will have to be made on a case-by-case basis. Also, something a lot of people want to know, is there something that you can do to reduce your risk of developing blood clots? The biggest thing that people in general can do is to stay active, meaning minimize your time sitting in a chair. That's one factor that makes people more prone to developing clots. So exercise is great, but even if you can't exercise, even just walking around the room or doing some stretching exercises, or even jumping jacks if you can. Other than that, you're going to want to take your doctor's advice on how to optimize your health. So that's all for this video. Hope you enjoyed it, and I'll see you in the next one.